Okay, so just to give you an overview on how a drug is approved in Europe. Now, you have to understand that the European Medicine Agency has been developed in 1995, and then through different readjustments of its legal framework, then it came in full power in 2005, and now a major legal change has happened 2 years ago with the introduction of the new pharmacovigilance regulation. But basically, what was the requirement initially was to put together all countries in Europe that probably had different drugs or had similar drugs approved at the national level. So basically, there was a need of recognizing drugs that were approved at the different national levels with one European European approval, and that was what happened with the mutual recognition. Now, the mutual recognition process is a process where a drug that is on the market in more than 3 countries is in Europe can apply, or a company that has a drug in more than 3 countries can apply for the approval at the European level. Now, usually, for some drugs that have very big interests, so for orphan drugs, for biologicals, for advanced therapies, for drugs in cancer, neurology, diabetes, and cardiovascular disease, there's a mandate. Any drug that has to be put on the market in Europe has to go through what we call centralized procedure. So has to go to put an application at the European Medicine Agency. The other possibility is to go through a decentralized procedure. This decentralized procedure basically is that the company applies to a member state, and then the member state is the reference member state, and the other member states can comment, and if there's agreement, the drug is approved. If there's no agreement, then the drug goes to the central committee for further approval. So the centralized procedure is pretty straightforward. It works very well, and it's very efficient. Usually from the application to the approval, it takes 240 days. So it's the company is given the first day the clock starts, and then the clock has to finish on 240. And it's compulsory, as I said, for the biotech, for specific therapeutic areas, and for orphan drugs, but while it's optional for other drugs. Now, the other 2 options, there is the mutual recognition, as I said, and the decentralized procedure. Now, for cardiovascular drugs, the majority have to go through a centralized procedure. Now, let's see what are the requirements for the different type of clinical trials that we have for an approval in cardiology. Now, regarding ischemic heart disease, we have drugs that can be approved for acute coronary syndromes or for chronic stable angina. Now, for acute coronary syndromes, then we can still have the differentiation in STEMI or non-STEMI. And for chronic stable angina, then we have, and we will discuss that later, the antianginals mainly, or drugs that have a prognostic effect in chronic stable angina. Now, in acute coronary syndromes, so STEMI and STEMI, basically we are interested only in mortality. So mortality, reinfarction, and stroke. And the cardiovascular mortality, what is important is the in-hospital or at discharge, the 30-day, 3 months, and 1 year. Then these are the time points that you have to consider in terms to look at efficacy. And then what other endpoints that are important are the occurrence of reinfarction or occurrence of sudden death, and definition of sudden death or even definition of ischemic death. It's important. So for this point of view, the adjudication committees are extremely important. Just think at the situation of a patient that has been discharged after an acute MI and then has, say, a car accident and dies. So did he die because of sudden death? Did he die because of a car accident? Did he die because of an acute MI? So it's an important issue, and so this is why for such type of trials the adjudication committees are important and DSMBs are also extremely important. So for acute coronary syndromes, the issues are pretty straightforward. You need to look at the major cardiovascular events of a discharge, 1 month, 3 months, 6 months, 1 year. In chronic stable angina, we have a different situation and different scenario and can be more complicated. Now, we know that treatment for chronic stable angina, and we know that from the guidelines of the European Society of Cardiology, can be for relief of symptoms or for prognostic improvement. So we can either have treatment of some risk factors or antianginals. So we can have drugs that can be approved for the improvement of angina or for the treatment of some risk factors. So if we talk about lipid profile, for example, then the short-term and long-term safety in patients with established disease are less important. What is important is an approval on major cardiovascular events. So if you want to have an approval for prevention or an indication in patients with ischemic disease for lipid lowering therapy, then you need to show effect on major cardiovascular events. So from this point of view, I mean, if you look at statins, it becomes pretty clear that you have Simva, Prava, Atorva, that are the only 3 drugs that have shown mortality benefit and prognostic benefit in patients with coronary artery disease, and while the others have not. Similarly, if we look at blood pressure, then we know that for primary prevention we can have an approval that is based on the blood pressure reduction, and this is usually the approval is granted on a short-term study that is a 12-week period, then short-term versus a comparator, and then but then in patients with disease, if you want to have an indication of an antihypertensive as a preventative strategy in patients with ischemic heart disease, you need to have a study on major cardiovascular events. Now, think at the, and we have from all of this only one example of one antihypertensive drug that is approved as for prevention of future cardiovascular events. Actually 2, and these are perindopril and amlodipine, and the combination of perindopril and amlodipine, because these are the only 2 drugs that have shown reduction of events. I mean, we should say that technically the reduction was only with perindopril. Amlodipine was just there and not really showed a clearly significant reduction of events. But in regarding the other issue of anti-ischemic agents, now the issue is have we got any anti-ischemic event that does reduce mortality or morbidity? No. We don't have any evidence that there's any single agent, any anti-ischemic agent that reduces mortality. There's no evidence for beta blockers. So beta blockers, except beta blockers in LV dysfunction post-MI, in chronic stable angina, there's no evidence that beta blockers reduce mortality. Not the slightest. So there's not a single trial, and nor even morbidity. And the same, we don't have evidence for the calcium channel blockers, we don't have evidence for the newer drugs. So the only thing where we can base our judgment and where we can give enough provability is on the degree of ischemia. So the drugs can be approved in the presence of inducible ischemia. Now, how can we assess inducible ischemia? So we can look at the exercise ECG. We can look at ischemia on Holter monitoring, on myocardial perfusion, or stress echo. The problem is the reproducibility of stress echo, especially in large multicenter trials. I say that even resting echoes in large multicenter trials that require centralized reading is really poor, and that is done just to please the CRO, because there's no way. I mean, just to give you an example, we several years ago, it was 4 or 5 years ago, we ran a trial with cyanoranidine receptor blocker, and we had 20 patients screened, and the echoes were, I mean, of course, patients with heart failure, and you can get all sorts of patients with heart failure. So you can get extra beats, you can get obese patients, you get patients with fluid retention. And so of these 20 patients, I think two or three were deemed adequate, had echoes that were deemed adequate from the coordinating lab, while all the others were discharged. So we thought we were our center was very bad, and then we sent all the echoes for review at an Italian lab that was the core lab for the for echo, and was for accreditation of echoes, and they said they were very good. So there's always an issue with core labs, and so echo is not adequate from a regulatory point of view, because it super selects patients and also wastes a lot of money. And I mean, if I were a sponsor, I would never ever select a core lab for assessment of echo. Then there is an issue of myocardial perfusion, and now myocardial perfusion also has variability, and also there's not a precise quantification, and so there is also the issue of quantity of radiation in different patients, and so the standardization is just not there, so it cannot be used. The same is for Holter monitoring. I mean, we all know that total ischemic burden is important. If there's more than 60 minutes of total ischemic burden, that is important. But then we know that there's a variability on exercise activities in all patients, and so we cannot use Holter monitoring from a regulatory point of view. So we are just left with exercise ECG. And so exercise ECG is the only parameter we use for regulatory purposes. And the assessment of the antianginals will be done on exercise time during exercise testing. So, and this is based on the fact that you pursue a benefit. Basically, you see a benefit if the anti-ischemic has an effect on ischemia and on angina. The patient will be able both to go longer because of less ischemia, but also because of less angina. And this is why it has been chosen to the exercise time rather than time to angina or maximum ST segment depression as an indication of as the main endpoint for a trial in ischemic heart disease. Then other points that are important are time to 1 millimeter of ST segment depression. I mean, from from a speculative point of view, probably time to 1 millimeter of ST segment depression is more important in terms of mode of action of the drug. But from a regulatory point of view, total exercise is more important. Other endpoints that are important, but they are supportive data, so you cannot grant an approval on those endpoints, are the quality of life questionnaire, the number of episodes of angina, the number of GTN tablets that are used during the study. The study that have to be used are the therapy against placebo. This is the initial study that has to show efficacy. Then another study against a comparator. Now, usually the comparator should be a beta blocker, although some drugs have used a mixed bag of beta blockers, calcium channel blockers, and nitrates as comparators. Usually we tend not to like it. It's I mean, the Americans like it. I mean, we are more rigorous. But usually, if you do a trial, the trial should be clean, and you have to have just a clear clear comparator. Or you can have your tested drug against beta blockers and anti-anginal or anti-anginals. So this is the note of guidance, that is the 2005 note of guidance on anti-anginals. And it recognizes that there's paucity of information on prognostic effects, that there are drugs that with novel mechanism of action. This was written when there were drugs like ranolazine and ivabradine coming on the market, and so we were foreseeing this application, and so the note of guidance says that it has to be that the drug has to be studied in the acute stress testing. The criteria for efficacy on a standardized exercise testing. Now, it is important also the type of exercise testing you use. You can use, if you use a treadmill, you can use either a modified bruise or a bruise protocol. Usually with a modified bruise, you see more, it's a more significant effect because it's a more gentle exercise rather than if you use a bruise protocol. Usually it lasts less and therefore you see less of an effect. This is important also when you assess and when you read the different trials. It's always important to look at the type of exercise test that has been used. And what is important also is that there's an adequate reproducibility of the exercise testing, because you know that if you have big variability and you show a significant effect that is within that variability, then it's lost. And we know that there is a variability in the exercise testing. So you need to show reproducibility, at least using 2 repetitive exercise tests. Now, the initial therapeutic studies should be done with off therapy, with withdrawal therapy, with the short nitrates are allowed. And this is important. If you're going to design a study on anti-anginals or in patients with ischemic heart disease, it is important that to know that you can withdraw drugs safely. It's plenty of data on safety of withdrawing or withholding anti-anginal medications for clinical trials if you do a placebo-controlled trial. And you can allow these short-term sublinguals. It's also important how long you give the sublinguals for, because if you give the GTN spray, then you foresee an effect that it lasts for 90 minutes. If you give the GTN sublingual, then you have an effect that is 3 hours. So it's important to, when you write your protocol, to know very well the pharmacology of the nitrates that you allow for your study. So that means that if your patient took the sublingual nitrate 2 hours before the study, you have to wait for another hour before doing your exercise testing. Then I will show you an example of the development plan of a drug that has been approved for the treatment of chronic stable angina. So you can see how the drug has been developed. So this was, ivabradine, and ivabradine has been developed with the first study that was parallel study versus placebo, testing 2.55 and 10 milligrams dose. And as you can see, as required by the agency, you have 2 exercise tests here. Now, the 2 exercise tests are conducted in order to see the reproducibility. So if you see more than 20% variability, then you cannot go further. So this is important because this is a way of to select patients for inclusion. Then patients are randomized, and then there is an exercise testing at the end. And the study basically showed a dose-ranging effect, and of course they showed not much of an effect of the 10 milligrams. There was little effect of the 10 milligrams with an increased risk of phosphates, and so the 10 milligrams at that time was dropped. And this is important. Remember that 10 milligrams was dropped in the development program, but not forgotten. and that is the problem. And then ivabradine has been tested with against atenolol. I mean, it's now you have only 2 drugs that have been tested against full dose of atenolol, and these are ivabradine and trimetazidine. All other antianginals have been tested either against nitrates or against a suboptimal dose of beta blockers. So, but only these 2 drugs have been tested against 100 milligrams of atenolol. So this is important in order to look at potency. And you see this was one of the, if you remember, one of the trial design that I showed you earlier. You can clearly see that that was a forced up titration. And basically, ivabradine showed similar effect to atenolol non-inferiority and superiority of non-inferiority statistically of ivabradine over atenolol, but superiority in terms of anti-ischemic effect per beat of heart rate reduction. Now, then probably you're aware of the recent data of the Signify, and but that basically led to a conclusion from the European Medicine Agency that there was no issue with the drug because it the issue seemed to be mostly related to the 10 milligram dose that it's not on the market, and so it was not an issue. So you see that the development plan was according to the to what was required by the agency. Then there was an extension study, and that extension study also tried to test an additional dose that was not on the market and that failed, and that led to possible regulatory interaction. So that, but that, I mean, that since the drug was not on the market didn't cause any other problems. Now, regarding the arterial hypertension, for the antihypertensive drugs, we refer to the note of guidance that is the 2006 note of guidance on products for the treatment of arterial hypertension. We will have the new note of guidance that will be out probably in June this year. And we're just waiting for the pediatric addendum to be published. What is important is that the antihypertensive drugs should be in the mild to moderate range, and the studies should include patients with relevant illness. And what is important is that if you test a drug, the drug should be tested through. So at the end of the effect of the drug, you never have to test the peak of the drug. So if you give the drug in the morning, you have to test the following morning before the next intake of the drug. So it's this is important because of to assess the effect of the drug. This is the type of studies that are required, and they're basically the same that I showed you earlier. And this is a clinical development program of one of the most recent drugs have been approved in hypertension, and this is basically aliskiren. Aliskiren went through a very extensive investigation plan, and I think some of the trial designs were very, very clever. And I will show you one of these just to give you an idea on how, with one trial, you can answer several questions, and now with one trial you can develop more than one drug. Some of them were done very, very well. So basically there was 1 dose selection studies, then 5 confirmatory trials, and 4 in mild hypertension. Then you see then a lot of efficacy studies. Now look at the design of this study. You may think that this was just a parallel study, but if you look more deeply, then it was placebo versus aliskiren versus hydrochlorothiazide versus the association. Basically, in one single trial, it was possible to test the aliskiren versus placebo, and so the efficacy of aliskiren, to test the effect of the fixed dose combination, because you had the comparison of the association of aliskiren hydrochlorothiazide with placebo, the effect of the aliskiren hydrochlorothiazide versus hydrochlorothiazide, and the association of aliskiren hydrochlorothiazide versus aliskiren monotherapy. This is important because the note of guidance on fixed dose combination tells you that you have to show that there's a benefit of the new fixed dose combination on top of what is shown by the single monocomponents. So you see that there was not just comparison of aliskiren with placebo or with a monotherapy or with another monotherapy, but was also looking at the association of aliskiren with what is required to develop a fixed dose combination. So I think this is the way of optimizing resources in one single trial. In this way, you cut the cost of the of your development by 50%. Now we are nearly to the end, so I see most of you are tired. I'm sorry, regulatory science is a bit tedious. It's, so regarding the heart failure, we have to differentiate patients with acute heart failure and chronic heart failure. Now, just to keep the story short, I mean, in acute heart failure, we usually randomize patients within the first 48 hours. In chronic heart failure, we randomize patients after 3 months of stability. So basically, we miss patients from after 48 hours of hospitalization to 3 months. And this is unacceptable, so we will come out probably in September with the Newton Note of Guidance that will take into account those patients. In fact, we have a reflection paper that it's already on the website of the agency, where we said that we are developing the Note of Guidance including these patients. So basically, we will be including patients who are hospitalized for acute heart failure, and this will be a major change because we will be the first drug agency that will be able to include either patients who are hospitalized but not acute, patients who will be discharged and looking at the effect of new therapies on discharge, or patients that are just discharged and can be treated. So this is a big change in terms of regulation in heart failure. And of course, then acute heart failure and chronic heart failure definition will be the same, but in the new Note of Guidance, there will be also the differentiation of per the reflection paper of heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Now, how do we assess efficacy? I've said already that because of the fluosequinone and the ibopamine issue, we need to have mortality and morbidity. In acute heart failure, usually we look at the in-hospital and 4 weeks mortality, and then depending on the indication that is claimed, the long-term mortality and duration of hospitalization, and then we will discuss that later. Then it is important to look at the improvement in the hemodynamic state and symptoms that can be put together in a categorical composite endpoint. And also you can have an improvement on the relief of manifestation of heart failure, including the inotropic support of vasodilators. This is important. I mean, if you're interested in acute heart failure, I mean, you may want to go and look at the design of TRUE-HF. TRUE-HF, it's a very cleverly designed trial with ularitide. I think it's very, very, very well done. In terms of cardiovascular mortality, at the present we ask for a mortality morbidity trial, either to confirm the benefit, and we will see what will happen in future, but also for any new pharmacological class or for any drug that may have a negative impact on mortality. And when we look at mortality, we need to have a differentiation between sudden death due to acute deterioration of clinical status, progression of congestive heart failure. It is important also to look at the composite endpoints. This is important. This is very important because heart failure is one of the conditions where you get a lot of hospitalizations. So you can reduce your sample size by putting repeated hospitalizations as in your endpoint. It has been calculated that you can reduce by 60% your sample size by using your repeated hospitalization, your recurrent events. Now, it is important in terms of recurrent events to choose the model that that fits better the population. So, because if you use, say, Patients in class 2 to 3, probably the patient journey it's better because it looks more into, gives more weight into hospitalizations. If you're looking class 3, 4, probably days alive out of hospital or the joint fragility model are better because they give more weight into mortality. Then there are other secondary endpoints that, but some of them like exercise tolerance may be considered if you have enough safety. Of course, it's important to look at safety aspects and in the development of drug, such as hypotension and organ consequences and pro-ischemic events. And but also, when we approve a drug, it's important to understand what is a meaningful change. So a meaningful change is any change in an endpoint that is correlated with mortality, morbidity, or that is significantly correlated with quality of life. So let's say we take dyspnea in acute heart failure. Now, this is what was shown by Relax HF with serelaxin. And so basically, if you look at the curves, it seems that was a very impressive, very nice reduction in the area under the curve of the VAS scale of dyspnea. There is a slight problem. I mean, the Relax 1 had been showed an effect on the Likert scale of dyspnea, and the study was designed to show a beneficial effect on the Likert scale, and the VAS scale was added later. So it's but then the regulatory requirement is not to look at the area under the curve, but at the effect at any given endpoint. So the actual effect was 4 millimeter. So this is 4 millimeter in a 10 centimeter VAS scale. So this was the question. I mean, Claudia and myself were rapporteur for Italy at the when we discussed the drug at the European Medicine Agency, and as you know, the drug had not been approved. So for us, that was not a meaningful change. I mean, you can clearly see that. I mean, you can hardly sell the difference, see a difference here in those 4 millimeters. Now, regarding exercise capacity, we have a very good example of efficacy in pulmonary hypertension. So we have Riociguat in pulmonary hypertension, and you see that Riociguat showed a significant improvement in exercise capacity compared to placebo, and that was significant. But then look at the macitentan for macitentan in patients with pulmonary hypertension. Now, macitentan had a significant effect on exercise capacity compared to placebo. Now, was 7.4 meters. Now, do you think that is significant? I mean, would you regard that significant? You're not convinced, and you wouldn't see that. I think that when you look at that, you more have to look at the effect on the stability compared to the deterioration. I think we have to learn from the way the people are managing to get drugs approved without any effect in oncology. I mean, I'm not saying that you need to have drug approved without any effect, but you have to look at now that mortality has been reduced, to look at the reduction of deterioration of an effect with your treatment. So that effect basically showed over long term that macitentan was associated with a better event-free survival compared to placebo. So basically that little improvement compared to the worsening of the placebo group basically showed that they were maintaining the exercise capacity and the clinical status while the placebo group was deteriorating. So that probably is maybe a meaningful endpoint, but just for a super-selected population of patients. So pulmonary hypertension or fibrosis like pirfenidone. pirfenidone is a drug that is a little bit controversial, but it showed that in patients that had less than 10% change in FVC showed a beneficial effect on survival, and that effect on survival was quite consistent. So the meaningful change, so apart from what are the requirements that are quite clear from the note of guidance, then it's important that those effects, the effect that you see on your clinical trials are meaningful. And the meaningful change is cannot be a fixed value. It should be just adapted case by case, has to be related to the baseline function. As an attenuation, attenuation of the decline of function, can that represent an important endpoint? I believe it does, especially in conditions like, say, advanced heart failure with cachexia, patients with significant comorbidities, and then it must have a biological plausibility. Thank you very much for your attention and for being still awake.